So in many ways, it's the valves that keep everything working properly. And as you are all aware, there are two sets of valves, and the anatomy of the valves dictates their function. So we need to know when the valves open and when they close, and you all know that during ventricular systole, the atrioventricular valves close to stop the blood running back into the atrial chambers, and then during ventricular diastole, the atrioventricular valves open, but the arterial valves close to support the column of blood then in the arterial trunks. So if we look at that situation here, I'm displaying to you the situation in ventricular diastole, which hopefully is known to all of you. The atrioventricular valve is shut. The ventricle is contracting to force blood out through the arterial trunk. So for the larger part of ventricular systole, the arterial valve is open. And then in diastole, as soon as the pressure in the arterial trunks is greater than that of the declining pressure within the ventricle, the leaflets of the arterial valve snap shut, and the atrioventricular valve is open. And it's these events that occur during the cardiac cycle that dictate the structure of the various valves. And if we're to understand the anatomy that permits the valves to open and shut under these varying hemodynamic situations, we have to take into account the so-called valvar complex. And I'm going to describe for you a valvar complex in the setting both of the atrioventricular valves, and that concept of a valvar complex has been very well established, and it's probably Perloff and Roberts who should take the credit for emphasizing the significance of the valvar complex from the early 1970s. It's less well established in the arterial valves, but for my money, the concept holds equally good for both sets of valves. So for the atrioventricular valves, we can truly describe an annulus, and I'll show you the annulus, but the essence of the valvar mechanism is the leaflets. And I'm going to describe leaflets in both the atrioventricular valves and the arterial valves. I know that many talk about cusps. Despite the use of cusp, I do not think that it's an appropriate use of this word, because a cusp, if you look at the Oxford Dictionary or the first definition in Webster's dictionary, a leaflet is a point or an elevation. And it's only of late that they've been bastardized into using cusp to describe the leaflets of the atrioventricular valves. And the leaflets are the components of the skirt of fibrous tissue that forms the closing mechanism of the valves. And so for my money, it is the leaflets that are the real working part of both valvar complexes, and for that reason we use the term leaflets to describe these components of both sets of valves. The essence of the atrioventricular valvar complex is the presence of a tension apparatus, and it's the presence of the tension apparatus that distinguishes the structure of the atrioventricular valves for those of the arterial valves. And of course, part and parcel of that tension apparatus, providing the link between the valvar structure and the ventricle, is the papillary muscles, or are the papillary muscles, because for each of the valves there is more than one papillary muscle. So this is the overall component of the valvar complex, and if the valve is to work properly, it's essential that all of these anatomic bits work in harmony. So here I'm showing you the parietal part of the left ventricle and the left atrium. It's difficult to understand at first, but this is the posterior part of the heart. So this is the back wall of the left ventricle. This is the back wall of the left atrium. This obviously is the aorta. And so if you're looking at the posterior part of the aorta, which coronary arterial orifice are you looking at there? The left coronary artery. Very good. And so here you're looking at the back part of the subpulmonary infundibulum, and this is the top part of the septum, which we'll be talking about very shortly. And it shows you beautifully the arrangement of the valvar complex of the mitral valve. And you can see very nicely the annulus. You can see the distinction between the mural part of the annulus here, the part of the annulus that is in continuity with the aortic valve. We're going to talk much more about that as time goes past. And you can see that hinged from the annulus we have the leaflets. Then beautifully you see the tension apparatus extending from the edges of the leaflets and connecting those to the papillary muscles, which are then intermediate between the fibrous components of the valvar apparatus and the musculature of the ventricular mass. And so all parts of this need to work in harmony. And if they work properly in harmony, then during ventricular systole, the leaflets fit snugly together, the tensor apparatus prevents the leaflets flipping inside out under the full force of ventricular contraction, and you get this exquisite picture of the mitral valve seen by, well, probably not seen by surgeons, because as has been pointed out to us, surgeons don't operate on normal hearts. This is what surgeons would like to see, having repaired the mitral valve. This beautiful picture was taken by a surgeon from Armenia who's called Dr. Val Galistan. I've never met this delightful man, but he sent me this beautiful picture many years ago now, and it's the most exquisite picture I have seen that shows you the closed arrangement of the mitral valve. And what you can see is that there is a mural part of the annulus into which inserts the vestibule of the left atrium. And note that the mural part of the annulus occupies 2/3 of the overall circumference of the mitral valvar orifice. There is then a second part of the annulus, and this is the part that is in continuity on the other side with the base of the aorta. So this is the aortic part of the annulus. And then if the valve closes appropriately and fits snugly together, then the key point in the mitral valve is that there is only one zone of apposition between its two leaflets. Now, if you look at the textbooks, you will see the ends of this zone of apposition marked as the commissures. In reality, however, the entirety of this zone of apposition is a commissure. Because what does commissure mean? Those of you with an Italian background will know that commissure means a line of union, a junction, or a seam. So logically, the mitral valve should have only one commissure. Any structure with two moving parts can only have one zone of apposition between them. But since, according to conventional wisdom, it's the ends of this zone of apposition that are described as the commissure, we have taken the alternative approach and we've simply described this zone of apposition between the leaflets. And as you will see, distinguishing the zone of apposition between the leaflets becomes key when we come to understand the morphology of the left valve in the setting of atrioventricular septal defect. The essence of the normal mitral valve is that it closes along one zone of apposition, and the essence of the normal tricuspid valve is that it closes along 3 zones of apposition. Note that there are multiple slits in the mural leaflet of the valve, and note also that the zone of apposition does not reach to the annulus. This is the typical situation as you see it with the valve opened, and then you see that the tension apparatus provides uniform support to all of the free edge of both leaflets. Note that at the ends of the zone of apposition there are fan-shaped cords, but there are also fan-shaped cords supporting the slits between the components of the mural leaflet. So we simply describe free edge chords, we also describe basal chords, but the essential point is that the free edge chords in the normal heart supply the entirety of the free edge of the leaflet. Now let me extend that concept of a complex also to the arterial valves. And as I say, the valvar complex, as providing the essence of understanding of the atrioventricular valve, has a long history. It's less well established in the arterial valve. But if we look at arterial valves, again we can recognize leaflets as the functional part of the complex. The leaflets are supported within the arterial sinuses, the sinuses being the working parts of the arterial root. And then another key part of the valvar complex is the sinutubular junction. And finally, there is the ventricular support. You will note that at the valvar complex I have not nominated the annulus as part of the anatomic arrangement. And that is because the annulus, and what constitutes the annulus, is the object of much controversy. So let's look at what's happening in the structure of the arterial root. And here I am showing you the subpulmonary infundibulum having removed the valvar leaflets. And it shows you beautifully the essence of the junction between the ventricles and the arterial trunks. And you see that having opened the pulmonary trunk and taken away the leaflets, I can truly show you a ring that forms the union between the musculature of the ventricular mass and the wall of the pulmonary trunk. And this line marks the anatomic ventriculo-arterial junction. This line is a true ring, but I don't think anybody in this room would nominate this as being the annulus of the pulmonary valve. And that is because when you look at the attachment of the leaflets, you see that the basal part of the attachment of each leaflet dips below the anatomic ventriculo-arterial junction. And because of this, a crescent of ventricular musculature is incorporated into the base of each arterial valvar sinus. But then when you continue to trace the attachment of the valvar leaflets, you note that the semilunar attachments of the leaflets extend up here to the level of the sinutubular junction. And because of that, crescents of arterial wall are incorporated as part of the ventricle. So the essence of understanding is that the hemodynamic junction, marked by the semilunar attachments of the leaflets, crosses the anatomic junction. And it is because of that crossing of these two junctions that we can get this snug closure of the arterial valve, seen here in the aortic valve, as we look down upon it from the aortic aspect. And you see that the skirt of leaflet tissue at each of the 3 points where the semilunar leaflets come up to the sinutubular junction is attached and thickened at the level of the junction. And then you see the zones of apposition between the leaflets which close snugly to the centroid of the valvar orifice. So in the aortic valve, as in the tricuspid valve, and as we will see in the left atrioventricular valve of AV septal defect, we have 3 zones of apposition. But note that the peripheral parts of these zones of apposition are at the sinutubular junction, and it is these peripheral attachments that are conventionally called the commissures. But again, if we took a commissure in its literal sense, it would be the entirety of the zone of apposition that we nominated as the point of union between the adjacent leaflets, but we don't do that. So let's build up the arrangement of the valvar complex here now in the aortic root, where you see I have shown here fibrous continuity between the wall of the aorta and the aortic leaflet of the mitral valve. So in the aortic root, as in the pulmonary root, there is a circular structure where ventricular structures meet arterial structure, and this is the anatomic ventricular arterial junction. There is then a second ring, which is very obvious in the aortic root, and this is the sinutubular junction. But then the key to understanding of valvar function is that the hinge points of the arterial leaflets cross the anatomic ventricular arterial junction, and because of this semilunar hinge, triangles of aortic wall are incorporated as part of the left ventricle, whereas crescents of ventricular structure are incorporated as part of the sinus. And there is then a third virtual ring, and it is this third virtual ring that the echocardiographer nominates as the annulus, but note that it does not reflect any real anatomic structure. So if we put the whole thing together, the essence of understanding is the crown-like configuration of the attachments of the valvar leaflets. And spanning this crown-like configuration, we have the sinutubular ring marking the distal extent, the virtual ring marking the proximal extent, and then the true anatomic ring, the anatomic ventricular arterial junction. Which of these is the annulus? You pays your money and you take this. So moving swiftly on to the septal structures, 3 to consider: atrial, atrioventricular, and ventricular. The atrial septum, to put you into context, is that part formed by the oval fossa. And if we take a section across the oval fossa, you see that to our left hand we have the aorta, and the true septum is the flap valve. And the rims of the oval fossa, for the large part, are no more than infolded atrial wall, a significant point that permits us to understand of septal defects. For the atrioventricular septum, we need to distinguish between the fibrous part and a muscular part that we used to call a septum before we understood things properly. So here is the true atrioventricular septum, and that is part of the membranous septum seen here in a close-up of the aortic root in the middle of the heart. So here is the non-coronary sinus of the aorta. I hope you all recognize the aortic leaflet of the mitral valve, and this obviously now is the right atrium. So you see the crest of the muscular septum, and between the crest of the septum and the aortic root we have the fibrous part of the septum, which is crossed by the hinge of the tricuspid valve. And that crossing by the tricuspid valve has now divided this fibrous septum into an atrioventricular part and an interventricular part. And the dimensions of these two parts of the septum vary from specimen to specimen, depending on the degree of delamination of this septal leaflet of the tricuspid valve. But this fibrous structure here is the only atrioventricular septum. In the past, we thought that the structure I'm showing you now was a septum. But when we look at it carefully, you'll see that in the area between the attachment of the leaflet of the mitral valve on the left side, the tricuspid valve on the right side, there is an overlap of the distal margin of atrial myocardium in the septal vestibule and the crest of the ventricular septum. And these structures truly separate the right atrium from the right ventricle. But what you will also note, if you look very carefully at this area, is that interposed between the two components of musculature, the atrial musculature, the ventricular musculature, you have an upward extension of the inferior atrioventricular groove, and contained within that fatty tissue is the artery to the atrioventricular node. So this area, although it separates atrium from ventricle, contains in its middle an extension of the outside of the heart. So rather than being a septum, this area in reality is a muscular sandwich. As we will show you, it is lacking in atrioventricular septal defect, but it is not strictly an atrioventricular septum. Now, to complete our review of septal structures by looking at the ventricular septum, you will now appreciate that the inferior part of the fibrous septum is oftentimes interventricular. But our attention now is on the muscular septum, because in the past, again, we made mistakes. There is no question that the apical part of the septum separates apex of right ventricle from apex of left ventricle. So we can truly call this the apical muscular septum. But in the past, we called this part of the septum, hugged by the septal leaflet of the tricuspid valve, the inlet septum, and we called the back part of the subpulmonary infundibulum the outlet septum. And we know also that this is not strictly true. Because if we take an oblique section through the inlet part of the right ventricle, and this can readily be obtained by the echocardiographer, insunating the patient from subcostal position, and hopefully you will recognize the various structures. So obviously here we have the right atrium. Very nicely here you see the coronary sinus. And you note that our section has taken us through the back of the aortic root, so that now we see again that membranous part of the septum, and we see it divided very nicely by the septal leaflet of the tricuspid valve into a large atrioventricular component, a much smaller interventricular component. But now my section shows you beautifully that the septum that in the past we called an inlet septum, in reality separates the left ventricular outlet from the right ventricular inlet. And this, of course, is a consequence of the normal wedged position of the subaortic outflow tract. And rather than being an inlet septum, in reality, this is an inlet-outlet septum. And it is an appreciation of this fact that permits us to understand the anatomy of ventricular septal defects. And then finally, when we look at the parasternal long axis echocardiographic section, a section familiar to most of you in this room, we see another crucial feature of what we used to call the outlet septum. For purposes of orientation, as you all know, the parasternal long axis cuts through the left atrium, the left ventricle, and the aorta, and it also cuts through the infundibulum of the right ventricle. And the key to understanding right ventricular structure is to appreciate the pulmonary valve is supported by its own sleeve of infundibular musculature. And it is the presence of that infundibular sleeve that permits the valve to be taken away and used in the Ross procedure, so that this area, which we used to call the outlet septum, as you see, separates the cavity of the infundibulum not from the left ventricle, but from the coronary sinuses of the aortic root. And if we go through there, we do not enter the left ventricle, we enter this tissue plane which separates the front of the aorta from the back of the infundibulum. So this is the freestanding subpulmonary infundibulum and is not an outlet septum.